औज़ुबिल्लाहिमिनश्शैतानिर्रजीम बिस्मिल्लाहिर्रहमानिर्रहीम अस्सलाम वालेकुम एंड वेलकम। आज आप सब लोगों को मालूम है कि शॉर्ट केसेस का सिलसिला शुरू किया हुआ है। शॉर्ट केस शुरू करने से पहले आज की अहम बात कि रोज़ाना के गोल्स बनाएं, हफ्ते के गोल्स बनाएं, इससे ज़्यादा का गोल मत बनाएं। रिमेंबर, परसिवरेंस इज़ नॉट अ लॉन्ग रेस, इट्स मैनी शॉर्ट रेसेस वन आफ्टर द अदर। आज के सिलसिले का शॉर्ट केस है हेमीप्लेजिया। सो आपको कमांड आ सकती है लाइक अ 7 year old चाइल्ड विद वीकनेस ऑफ वन हाफ ऑफ द बॉडी, प्लीज एग्जामिन गेट एंड रेलेवेंट। सो लाइक ऑल शॉर्ट केसेस आपने इंट्रोडक्शन लेनी है, consent, after that sanitization and exposure, and when you are exposure do the hand sanitization before. Then in all short cases go for the general look in which you see whether the child is sick looking or well looking. Is there any cyanosis or respiratory distress at rest? Is there any pallor or jaundice? What is the nutritional status of the child? Diagnostic or dysmorphic features. Interventions such as oxygen, NG tube, cannula, and count the respiratory rate. Ask the name of the child to assess the speech, which can tell you that whether the child is having aphasia or dysphagia in stroke. Then check the gait of the child. In case of hemiplegia, the gait will be circumductive. So circumductive gait, this is the circumduction gait. See, the right side is rotated around the posture. It is rotating around like in a semicircle. So this is called a circumductive gait. It's very pathognomonic of that hemiplegic gait. And remember that if there's a fog test and a reverse fog test also tells us about the subtle hemiplegia. After that, you do the complete motor system examination of upper and lower limb, including tone, power, reflexes, clonus, and plantars. Then do the superficial reflexes, which will be absent in upper motor neuron lesions. Then see the hands for clubbing, oscular nodes, Janeway lesions, pulse, then radio, and radiofemoral delay of the pulse, and BCG scar. So this is the pictorial representation of the Janeway lesion and oscular nodes. Oscular nodes are very tender. After that, you check the cranial nerves. First in the eyes, you check the extraocular movements, H sign to check 3, 4, and 6 cranial nerves. They will be pallor in case of acute lymphoblastic leukemia. There can be jaundice. Then you check the fifth nerve, and in the face, you check the seventh nerve to see the nasolabial folds, eye closure, eighth nerve by checking hearing. And when you open the mouth, you make the child gag and R reflex for the ninth and 10th cranial nerve. Then ask the patient to protrude tongue for the 12th cranial nerve. Check signs of meningeal irritation for meningitis. Auscultate the cardiovascular system for the murmur, which can be a sign of infective endocarditis. Abdomen, palpate liver and spleen for SLE, and it can be also in infective endocarditis. Splenomegaly for infective endocarditis. Check the back or spine for bed sores and LP dressing. And screen skin for the petechiae and bruises, neurocutaneous stigmata of neurofibromatosis. Offer fundoscopy and blood pressure checking at the end of the examination. Now, I have made a description of a hypothetical patient. You can make your own. So this is just to make you fluent when you are telling your examination. So practice this also. So I have just examined 6-year-old Junaid Khan, who is thin, lean, well-looking child without obvious jaundice, pallor, respiratory distress, and cyanosis at rest. There is no diagnostic or dysmorphic features. Child was conscious and cooperative during my examination. The child was having circumductive gait on the left side. Motor system examination revealed hypertonia on the left side with a power of 2 by 5, exaggerated reflexes with upgoing plantars. The examination on the right side was normal. There was upper motor neuron type facial palsy on the right side of the face, while other accessible cranial nerves examination was normal. Superficial reflexes were absent. There was no clubbing, koilonychia, osseous nodes, and GNV lesions. Pulse was 80 per minute, normal volume, regular in character, without radial or radiofemoral delay. The BP is 90 by 60 millimeter of mercury. There was no signs of meningeal irritation. Heart sounds were normal in all areas of auscultation without murmur, and there was no hepatosplenomegaly. There is no petechiae and pallor. Normal speech and examination of back was normal. My examination is consistent with left-sided crossed hemiplegia, most likely due to. The differential diagnosis can be many, but you have to remember at least three. Arteriovenous malformation, hypercoagulable states like protein C and S deficiency, factor 5 Leiden mutation, antithrombin 3, and as well brain. Investigation of the hemiplegia. Before telling the examiner, you say some of the investigations will be for the diagnostic purposes, some for the supportive purposes. Here only typical investigations are given like imaging, CT scan, MRA, MRV, in hematological complete blood count for hemoglobin and platelets. Then do the coagulation profile like PT, APT, protein CNS level, factor 5 latent mutation, antithrombin 3 level. Then autoimmune profile like ESR, CRP, ANA, NDDS DNA antibody, C3 and C4. Then echo, then infectious etiology is ruled out by performing the CSF, then metabolic screening, checking the homocystinuria and Wilson disease, then the lipid profile. So the management of hemiplegia is mainly supportive and it includes physiotherapy, speech therapy, care of the bowel and bladder, diet and posture change. Definitive treatment for the ischemic stroke is rule out bleed and then treatment depends upon the cause. For hypercoagulable causes, do the reperfusion therapy in the form of thrombolysis or thrombectomy. The options available are streptokinase 0.1 to 0.2 mg per kg per dose, 6 to 12 hours. Low molecular weight heparin is given and then warfarin is given in a dose. So this was just the basic guidance and you can make it better or you can improve it as per your understanding and knowledge, but my aim was just to give you a basic guidance. Thank you very much and you're welcome. I will be looking forward for your feedback. I pray that may Allah be our helper, protector and guide. Allah Hafiz.